Good morning, everyone. And thank you for joining us this morning. I know it's a very busy, short week for a lot of you. And thank you, Dr. Gowd, for agreeing to present to us this morning a very timely topic. And just some statistics before we start. According to the International Diabetes Federation, we are leading the world in terms of our region with impaired glucose tolerance at a rate of just around or over 12%. In 2001, hypertension was the third cause of death in the Bahamas. By 2011, it was the #1 cause for death. So I say all of that to start to encourage us that Dr. Gowd's presentation is timely and very needed. And most of you would have seen, as I posted this morning, based on the 2019 STEPS study, 35% of patients report being given any type of exercise or healthy lifestyle advice at physician or medical visits. So there is certainly room for improvement, and we thank Dr. Gowd for talking to us on this subject. So Dr. Gowd, he obtained his master's in orthopedic surgery from Manipal, India. Being passionate about sports, this drove him towards obtaining a postgraduate diploma in sports medicine from the Olympic Committee, as you can see in his lovely picture. And he obtained this from the Olympic Committee in Switzerland and a diploma in football medicine from FIFA. He trained in sports trauma and arthroscopic ligament reconstruction at Miami and Sports Trauma Research Institute in Oslo, Norway. His area of interest being minimally invasive and ultrasound-guided musculoskeletal procedures, from which he trained at National University of Singapore. He is a doping control officer for FIFA, certified advanced team physician by the American College of Sports Medicine, and ATLS instructor by the American College of Surgeons. His primary interest being injury prevention and educating amateur athletes about exercise and sports physiology. Having a vision to provide international standards of care, with his immense experience and expertise in the field of sports medicine and trauma, is his professional goal. And since Dr. Gowd joined us for CME a few years back, he has since welcomed twin boys. So congratulations, Dr. Gowd, and welcome.
Thank you. Okay, a very good morning to all of you. I hope you're all doing fit and fine. I just want to make sure you can all hear me and see my slides before I start. Okay, so today I'm going to be talking a little about exercise prescription. It's something that's been present, nothing new, but we're just going to reinforce and see how it could make a difference to our patients in their daily life. I have nothing to disclose. Today we'll be talking a little about the epidemiology. Dr. Black already gave us a little introduction about the seriousness of lifestyle and chronic diseases and how exercise can help such patients. We're going to talk a little about the terminologies, the maximal heart rate, the VO2 max, MET, and RPE, so that we understand when we do prescribe exercises, what these terminologies mean, how to come to calculations, and at what percentage of these do they have to exercise. We all know the benefits of exercise. I'm just going to reinforce it again. We're going to look into the different types of exercises, how to prescribe, and we're going to look at a few specific groups of patients that benefit from these prescriptions. As Dr. Black already said, that diabetes, hypertension, but when I looked up, I found this slide. This is a little old data of the Bahamas, but you can see that cardiorespiratory and neoplasm make up almost half the mortality cases in here. So that's how important it is to focus and try every modality. We already have medication, surgical management, but the non-invasive, something that's very cost effective, is exercise therapy. So that's something we're going to talk about today. So currently about 60% of the world population is not active enough to get benefits from exercise and reap the benefits for their better health. So as back as in 1950, they had a retrospective study wherein they compared the health conditions of bus conductors and drivers, and they found that the conductors who are more active compared to the bus drivers had lower incidence of heart disease and general health as such. So there have been multiple studies that have proven time and beyond that exercise does make a difference, not just to the overall quality of life, but in general in other conditions too. So inactivity can actually complicate the pre-existing conditions like obesity, heart disease, diabetes, hypertension, cancer, and arthritis. So what's also important is to have it consistently, because if you have periods of physical inactivity, that's where you can have those complications come back. So just the way we take precautions from lifestyle, diet, and medication, exercise has to be a lifelong adjunct for patients. So there have been multiple studies that it's helpful in hypertension, stroke reduction, colon and breast cancer, diabetes, and obesity. And these are a few of the conditions that we will talk about later in the presentation as to what specific exercises are helpful and a few contraindications for each of these categories. So what exactly is physical activity? It's any bodily movement produced by the skeletal muscle system that results in increase over the resting energy expenditure. So you could either do it during leisure or you could do it as a scheduled physical activity. So coming to a few important terminologies, we all have heard of this term as the maximal heart rate. It's a very simple formula. There have been multiple studies with different equations as to how you can come to these heart rate. So the most commonly used is 220 minus your age. It's not the most accurate, and depending on each categories, the one that we could use for our patients is 206 minus 0.88 into their age, so that's their maximum heart rate for exercise. And depending on that, when we say 50%, it's going to be 50% of this particular number that they have to exercise at. Other terminology is the VO2 max. It's a maximum amount of oxygen that's consumed. Usually it's done more accurately in laboratory testing, but in general, the higher the number, the better your cardiorespiratory fitness is. So how do you calculate this if you're not in a laboratory setting? So the Fick equation originally was more for the laboratory, where you have Q as a cardiac output, that's into the difference of the oxygenation in the arterial and venous blood. But much more simpler formulas have come out wherein you can just have your maximal heart rate and your heart rate at rest divided and multiplied by 15.3. But a more accurate and practical one is the Rockport Fitness walking test, wherein you walk for 1 mile and you see multiple numbers in here. So the most important one is to know the patient's weight in pounds, their age, and gender, because if it's a male, that number stays and multiplies by 1. If it's a female, it just nullifies a 0. And the time that you take to complete that 1 mile and your heart rate at the end of 1 mile. So you have to walk at the maximum pace, but not jog. So once you have these numbers, you can have a pretty reliable VO2 max. So what does these numbers mean in terms of different age categories and different fitness levels? If you focus on the extreme right, today we're going to be focusing more on the elderly because that's where our major population is for the patient, but we'll talk about children and young people as well. So you also notice that the VO2 max varies not just by age, by gender as well. So once you have your VO2 max effort, and then you have your maximal heart rate, this is just a representation wherein you have your percentage of your maximal heart rate and you have your age in here. So let's say, for example, for a 50-year-old gentleman, his heart rate max is going to be 220 minus 50, that's 170. So if you say that he has to exercise at 80% of effort, that's going to be between 136 to 153, 80 to 90%. And that's where you have your aerobic training, sorry, anaerobic, and you have your aerobic below that. So all it means is whether you're having exercise that's consuming oxygen or not having oxygen in the exercise. So anaerobic is more of very high intensity sprints and activity, whereas aerobic training is for your cardio, for your running, cycling, and jogging. So these are the various categories of exercise intensity for different prescriptions. So, but these, the numbers that we've spoken so far is more of a calculation. So Bohr came up with a scoring system, which was initially from 6 to 20, depending on the intensity, but it's been remodified from a score of 1 to 10. This is similar to probably what we use as a visual analog score for pain, wherein the exercise intensity is expressed by the patient or the person, because this is what they perceive. And this is been a crucial parameter for understanding the level of fitness, understanding their VO2 max, as well as their intensity of exercise of how they feel. Because the same exercises can be fitting into different categories for different people based on their fitness level. So on the left, you see the original box scale, wherein it was from 6 to 20, 20 being the maximal intensity, and it's been modified from a score of 0 to 10. So during the presentation, we're going to be using these terms so that you have a better understanding of what we are looking at. Now, MET, it's a metabolic equivalent. You would have seen this in a lot of the gym equipment wherein you select as to what MET you want to exercise it. Basically, one MET is your resting metabolic rate, which is about consuming 3.5 milliliters of oxygen per kilogram per minute. So you can derive a MET into the total number of calories that you need to are basically burning during an exercise. So if you want to convert number of METs into kilocalories per minute, you basically have to multiply the number of METs of the exercise into 3.5 into your body weight in kilograms and divide it by 200. That's your kilocalories per minute. For example, if you have a 88.6 kilogram man cycling for 2 hours at 12 miles per hour at MET of 8. So what it means is you do your calculation and it comes up to 12.4 kilocalories a minute. And then you multiply by the time duration that they've exercised for, and that's what you get. So all your fitness watches, what they do is basically they ask you to enter your weight, your parameters, and they use these different algorithms and equations to come to conclusion as to how much you've been burning calories. Of course, they use your heart rate as well. There are many more complicated equations, but I'm sticking to the basic that's more practical for us in our clinical setting where you don't really have to go to the laboratory to test them. So to give you an example of what MET correlates to the kilocalories based on the formal exercise and home activities. Now we got to remember that when we talk to a patient or prescribe, not everyone would have the luxury or liberty to have formal exercising. Sometimes you have to tailor it to their home needs and their home activities. So that's how understanding these scoring systems, the calories and the MET is useful in prescribing for these patients. So coming to the various resistance training, or what you call as weight training, you have an isometric, isotonic, and isokinetic. So what are these terminologies? What do they mean? An isometric is wherein you are doing exercise against the resistance. So the length of the muscle doesn't change. Let's say, for example, on the bottom you see here, doing a plank exercise, wherein the patient is putting effort, but there is no movement. So this is an example of an isometric. An isotonic is wherein you're pulling a constant mass with varying degree of acceleration and deceleration, like if you're doing a kettle push-up or weight exercises, or you're doing your biceps curls, that's where you have an isotonic. And an isokinetic is wherein your velocity of exercise is constant. If you're doing a stationary bike with your legs, that kind of an activity is an isokinetic. Now we use these terms called concentric and eccentric. So concentric is nothing but when you're doing a biceps curl, when you work against gravity, you're shortening your muscle. So whenever you exercise to shorten your muscle and the contractile force, that's your concentric. And your eccentric is when you are resisting the elongation of the muscle, but the weight or the resistance that you're going against is going to pull it and stretch it out. So different patient categories and different conditions have a requirement for concentric and eccentric. Most of the rehab and strengthening patients require eccentric. And circuit training is basically a mix of all the exercises to make it more interesting for them. So what are the benefits that we have of doing exercises? So you have health-related benefits and skill-related. So the health-related is when you exercise, you improve your cardiorespiratory endurance, your body composition improves, you have more muscle strength, muscle endurance, and you have more flexibility. The same thing when you apply to skill, you have increased agility, you have more coordination, better balance, power, your reaction time is reduced, and your speed of doing activities improves as well. So what are the various ways that exercises can help? It can reduce the need for prescription medication. There have been multiple studies that have showed that in lifestyle diseases. You can prevent weight gain, you can promote weight loss, improve quality of life, increase chances of living longer, you have better sleep, you are psychologically in better moods, and then there have been studies that show that your total number of productive hours actually improve when you exercise compared to having a sedentary lifestyle. So the American College of Sports Medicine has a lot of literature and a lot of data, and these are some of the statistics from their information that they have. Now, getting into the flu season, it's also shown that having regular physical activity and exercise can actually reduce your duration of symptoms, where if you have it for 10 days, it can actually reduce it to a week. So that's a significant morbidity reduction in terms of productivity for life and having more time that's healthy. So what are the changes that happen in general with aging? You have decreased bone mineral density, you have decrease in the muscle mass and strength, you have respiratory effort and lung capacity that reduces because these muscles of respiration also undergo sarcopenia over time. So your ability to have more oxygen exchange also reduces, and you have brain atrophy and increased latency period. So it involves a multi-system, not just one particular system. So this is the physiological changes that happen. So this is something that's inevitable. So we have to exercise to kind of minimize the losses that the physiological changes happen with age. So all these things, when you put it into perspective, the VO2 max reduces. We know that the maximal heart rate is dependent on the age. So as you age, that's going to come down. Your cardiac output decreases. The only thing that increases is blood pressure, stress, and the chances of getting more diseases. And the metabolism also is going to reduce at a rate of 1 to 2% after the age of 20 per year. So that's a significant reduction. So coming to how much do we exercise or how much should we exercise? So there are various studies, and this is the latest guidelines for an average healthy individual. Now, this has to be tweaked around a little based on the coexisting morbidities so that the intensity duration can be altered. So for an average healthy or minimally symptomatic patient, 150 minutes of moderate intensity, 75 minutes of vigorous intensity per week is a good mark to have exercises. So you got to balance the training in terms of the cardiorespiratory, do muscle strengthening or resistance training so that you have a balance of all the exercises over the week, along with flexibility, stretching, and neuromuscular coordination. So now, what are the components of any exercise training? So before you go into conditioning or the main exercise, it's very important to have that warm-up based on your needs, because that also conditions your body for the strain that you want to put the body into, have better mobility, range of movement, and also reduce the risk of injury and other complications related with exercise. The cool down is also equally important, and stretching as well. So these are the 4 components of any exercise that we want to prescribe. So what we've spoken so far is a little numbers in here that I've put up, so you understand the correlation of METs with age and what it means with the VO2 max percentage and the maximal heart rate compared to light exercises and vigorous exercises. So basically what it means is less than 2 METs is light exercise, and the higher METs you go, the more intense it is for exercise. So those are all the tests we spoke about calculation. But if you had a very simple and the most effective test, I would say it's a talk test. And what it basically means is when you go for a walk, if you're able to talk and sing at the same time, or talk and sing, that means it's light intensity exercises. If you're able to talk, but you're not able to sing when you exercise, that's moderate intensity. If you are unable to talk when you do that particular activity, and that's when it is a vigorous or a hard exercise. So if you have to basically tell your patients to check, talk, how do I know what intensity I don't have a fitness watch, I don't know, I don't have monitors, so how do I do that? So all you got to do is ask them to sing when they're walking. If they can sing, then it's light. If they can only talk to themselves or even to their friend or to their partner who they're walking with, then that's moderate. If they can't talk or sing, that's when it's a very high intensity. So what it correlates in terms of your perceived exertion scale that we spoke about, the box scale earlier, the VO2 max, the heart rate, and the MET, and a representation of the different age categories relating to their heart rate in terms of the intensity of exercises. So with the increased popularity of fitness monitors, or even with having apps on the phone, this is a rough guide about how many steps indicates what level of physical activity that you do. But it can be a little tricky in this because the number of steps you do is at varying paces. So someone who's done 5,000 steps by running or sprinting compared to someone who's done 10,000 steps by actively walking is a whole different category. But this is a vague scale that you could also use to see at which physical level, activity level you are currently. This is a very important thing to have in your office so that when you do prescribe, I'm not sure if you're able to see all of it, but you can have these printouts in your office so that based on their patient's interests and level of fitness and what level of fitness they want to achieve, you can prescribe various activities that could be either household occupation, specific sports, or a prescribed exercise regimen for them. So what are the components of a prescription that you give to a patient? So when you prescribe, the various categories that you're looking at are the frequency of exercise, the intensity of exercise, the time duration that they have to exercise for, the type of exercise, the volume and progression. So this is called as the FIT-VP protocol for exercise prescription. Now, when you look at a prescription of a medication versus an exercise, this is how it's going to look in terms of the contents. So exercise is walk for 30 minutes per day at the strength of moderate intensity, frequency of 5 days per week, and then you put in some precautions, and refills as forever. So the various types of exercises, you have cardiovascular, or most of the aerobic, you have strength training or resistance training, you have flexibility exercises and balance exercises. So coming to the aerobic or the cardiac exercises, cardiorespiratory rehab. So these are more of the rhythmic continuous activity like walking, biking, dancing, swimming, and water exercises. How often are they to be done? They can be done every day, but usually the reason we say 5 days is sometimes you do need a recovery period to recuperate from the exercises, and also to incorporate the other resistance training and flexibility based on your needs. So as we spoke earlier, 150 minutes of moderate intensity or 75 minutes of high intensity in a week spread over 3 to 5 days is good aerobic activity. So this is again the frequency, intensity, time, type, volume. Now a MET minute is basically how many METs of exercise you do into the number of minutes. So the target volume is anywhere from 500 to 1,000 per week. So since you know that the MET is directly, when you calculate the MET, it depends on your body weight. So the same intensity of exercises is different for people with different body weight. So that's wherein you have to be understanding the principles of exercise prescription. Strength training, what you call as resistance training, can be done 2 to 3 days a week, and then you can have light to medium intensity. So you could start off with 2 to 3 sets of repetitions from 10 to 15 and have about a gap of 2 to 4 minutes in between. So the most important thing in strength training is to avoid holding the breath. That's a common mistake that a lot of even healthy individuals do, trying to work out against resistance training. That can be of an adverse effect in people with cardiovascular issues like hypertension. So basically what you're doing when you hold your breath is doing a Valsalva maneuver, and that can have adverse effects. So that's something that to be very mindful about and tell all our patients that not to hold their breath when doing. If they have to hold their breath, that means they're putting in a little too much of an effort. So they have to reduce the intensity or the load of exercise. So intensity, now another terminology is called as repetition max. What it basically means is the amount of weight you can carry, the maximum amount of weight you can carry to do one repetition. So there are a lot of apps that you can download on your phone to check your R max, and then based on that intensity, you have to do different exercises for different people. Now, in the middle-aged and elderly, we try to reduce the weight and increase the repetitions so that there's less strain for them, so that they have better compliance and better outcomes. Flexibility and balance is a critical and crucial part of elderly exercises, because it also improves the range of movement. And the various exercises that you could do is static stretching, Pilates, flexibility exercises, and it has to be a stretch for 30 to 60 seconds, and you have to feel a light tightness. A lot of common mistakes that people do during stretching is to try and get that pain. That is not where you're supposed to be stretching up to. So when you feel pain, you relax just a little bit and then just feel the little tightness that gets released. So that's also an important component of your exercises. The various different types of stretching, you have ballistic, dynamic, static, active static, but the most important and the one that's relevant to our patient population and healthy people is static stretching, where you just hold the stretch, and unlike ballistic and dynamic, which are more in high intensity exercise and athletes, that they do it before sprints and other activities. So in elderly, it's important for them to hold a stretch from 30 to 60 seconds. That is better than holding it for 10 to 30 seconds, which is usually done for most common adult groups. Neuromuscular exercises or neuromotor training is key for people who are on the extreme of age, on elderly, because that kind of improves your coordination, balance, and reduces the risk of fall. Now, in my specialty, we see a lot of hip fractures, and that's usually because of fall. So it could be various causes, but one of the causes is not having a good balance coordination. So doing exercises like yoga, Tai Chi, these are things that can actually improve your neuromotor coordination skills. So coming to, now we've understood about the various exercises, the importance of it. So when you have a patient present to you, or a colleague or someone you have to prescribe a medication to, you need to understand the mindset. So usually it's in 6 different categories as to where they could fit in. So we're going to talk about each of them, where you have precontemplation, where they're not ready to accept or they're unaware of the problem. They have a problem, but they don't know what it is. That's related to exercise. So it's someone who comes in with uncontrolled hypertension or just having multiple body pains and says that medication are not working. When you introduce exercise or suggest exercise to them, they don't really think it would work. So they're almost like a denial. So that's the first stage of a behavioral change that need to be focused on, because that's when you have to talk to the patient, educate them to make them understand the benefits of exercise. And then you have the contemplation mode, wherein they start becoming more aware of their problem. They think of making some changes. They want to, and they're very wary, and that's why it's called an ambivalence, where sometimes they feel that they have to make some lifestyle changes, and other times they say that, no, I'm happy with what I am, I could continue, I don't want to bother with exercises. The next stage is preparation, where they actually want to, they accept that they have to have some changes to have exercise. incorporate into the lifestyle. And then they have the action phase where they actually execute it. And then you have the maintenance. Now in the maintenance, that is a very crucial stage where you could either have temporary cessation of exercises, lapse and relapse. But once they continue and be consistent, and then they will definitely continue and incorporate it into their life. Now, the positive changes that could disappear if you stop are, you tend to put on more fat content, your strength and endurance reduces. So it's important that maintenance is continued on till they reach the stage of termination, wherein they notice these changes, they're very motivated, and they very rarely go back into inactivity. So when you look at this particular pyramid, you have the vision, preparation, action, results. And these are various components that are actually supported and that you face at each of these levels. So when a patient comes to you, how do you know at which level of mental preparedness they are? So this is a question here, just 4 basic questions that you ask them. And depending on the results, then you can kind of estimate as to which stage of mental preparedness they are for exercise medicine, and then you can act accordingly. So I am currently physically active. Yes, so they're definitely in the minimum they are is in a preparation stage. If they say no, then you know that they're still contemplating, or they're blind to the idea of having exercises as a part of their life. I'm currently engaging in regular physical activity. I have been regularly physically active for the last 6 months. So these are very encouraging questions to ask and understand, so you know where they fit in. So what are the ways that you can prescribe, or what are the goals that you need to have? So it's called as a SMART goal. So we got to be specific for each patient, their needs. It has to be measurable, because when you just prescribe an exercise and they don't see the results, then they start questioning and doubting what we are suggesting to them. So it has to be specific, measurable, achievable, and realistic and timely. So we always have to start with very low intensity, reduce frequency, and as time goes, we have to increase them so that they also get more confident and continue. Because on day 1, if you prescribe very high intensity and they goal right on the first prescription, then that can be discouraging for them. So it's important to have these things in mind when you prescribe exercises. And the 5 steps of wellness motivation process is assessment, defining success, goal setting, establishing priorities, and taking control. So what do you need to know to write a prescription? Assess their medical risk, consider the age and current level of functionality, understand their goals, not yours, because they could be having certain different goals. What do they like to do for recreation, and design the program based on that. So you have to do some basic testing when they come in, like blood pressure, heart rate, muscle tone, body composition, the basic fitness level, cardiorespiratory endurance, and the flexibility. Now, these can be done either with a questionnaire or with actual laboratory or clinic testing. So a very useful tool which is standardized is called as a physical activity readiness questionnaire, which has a few questions that you ask when the patients or your clients visit you for exercise prescription. So has your doctor ever said that you have any heart condition? So you go through the 7 questions, and if any of them is a yes, then you have to go in detail and look for other conditions. You ask a few questions based on their history, their symptoms, their health issues like diabetes, hypertension. Are they pregnant? Are they having any other metabolic disorders that can interfere with exercises? So continuation and more specific, so in the cardiovascular, because that is a key component even in the assessment and as well as for functional exercises. So once you've done your initial assessment, they could fit into 3 categories, which is a high risk, moderate risk, or a low risk. Now, the high risk category, if they've had any history or they're currently having any conditions, that's when they fit in there. If they've been not diagnosed, but they have symptoms or signs of those particular diseases, they still fit into the high risk till they've been cleared. And then you ask for risk factors basically related to cardiovascular diseases like age, family history. And in that category, if they have more than 2, that's when you know they're moderate risk. And if it's less than 2 of these symptoms or factors, then you know it's a low risk. So basically what it means when you have to prescribe is anyone who fits in the high risk definitely needs a detailed medical examination before he starts any exercise. Someone in moderate risk needs a basic medical examination more for the vigorous exercises. They could continue with the moderate, but if they have to do vigorous exercises, that's when they have to medically clear. But someone who's at low risk, they don't really need medical clearance. They're ready to do moderate as well as vigorous activity as a part of their exercise regime. So again, a few indications wherein exercises have to be kind of evaluated, the patients have to be evaluated, and a few contraindications. Now, the final prescription is going to look like this, where you have your patient's name, the exercise prescribed, and then you have the fit, where you have your frequency, intensity, time duration, and the type. And you can plot it against a graph like a program that could be either like a weekly program or a daily program, and based on the number of minutes and the frequency. The darker it gets, the more intensity. So you can have various ways that you could prescribe, and then you write about the progression, about whether you want every 3-day increment, daily increment, or weekly increment, and if any precautions that I have to look into, and any other suggestions or notes, like especially in people with overweight, obesity, it's very important to focus on the energy intake as well. So those are the other notes that you put in there that go along with exercises that make a big difference in their health outcome. So what are the challenges that patients face, or that you hear about why they resist exercises? They say, I don't have enough time, not enough energy, they're not motivated, I have a child to take care of, there is no one to exercise with, it hurts. So these are all the real challenges that we face in our daily when we face patients. These are some of the problems that they come up with. So there are various strategies that you could have: group exercises, knowledge sharing, motivational interviews. So when they come in and you talk about exercises, I always do this whenever people come in with knee pain and I see they're a little on the heavier side. I ask them about their physical activity, their dietary habits, because not everything can be 100% treated with medication. Some of these actions actually make a small change in their symptoms. So that goes a long way. So it's very encouraging. So I do tell them stories about patients that have had weight reduction and how the significant reduction in pain and joint pain. So each of these can be incorporated in your specialties, and then they get more motivated and they at least give an attempt and a try. So that's wherein we need to intervene and kind of help them and understand what fits them the best. If they like listening to music, if they like walking on the beach, if they like walking in the park. So based on their interests and the environment, you can prescribe exercises. But of course, with this current pandemic, it's going to be more of home-based activities, which we're going to talk later about. So the support structure, it could be a long list from your spouse, from religious groups, social groups, personal trainer. But as physicians, we have to play our role and make sure that we give all the support to our patients in making sure they have a healthy lifestyle and exercise better. So circuit training is, as I told you, a very important part of exercise prescription to break the monotony of doing the same exercises. So you could kind of change the exercise every day so that they have more compliance. It also reduces the risk of injury, and you have more oxygenation and blood flow in the end organs as well. So this is a graph representing the frequency path, where you want to make sure that they continue with the same number of minutes and keep increasing the frequency. And as time goes by, increase the frequency as well as the number of minutes and the intensity of exercise. The same thing with the duration. You could increase the duration on the step ladder fashion. And the intensity, you see that you start off with the intensity and keep increasing the intensity. Sorry, maintain the intensity, but you keep increasing the force of exercises. When you have to increase the intensity again, you have to make sure that you go back to lighter exercises, and that's how you go. We don't want to increase the intensity right at the step ladder. That can demoralize them because they might not be able to sustain the level of activity, have pain, inability to perform. So that's important to understand as well. So what are the adaptations that the body has when you do these changes? You could have the central adaptations, peripheral adaptations, adaptations to the cardiovascular system, and musculoskeletal changes. The central adaptations that you have is increased VO2 max, your end-diastolic volume is increased, so you have higher stroke volume, and then you have hypertrophy as well, which is conditioning hypertrophy and decrease in the resting heart rate. So these are all the cardiac changes that happen when you exercise. The peripheral adaptations can be you have increased muscle mass, angiogenesis, you have more mitochondria. So basically what you're able to do is generate and increase your endurance and ability to perform exercises at a much more high intensity and capacity of strength as well. So let's talk about a few basic groups of patients that we see most often in our practice. And cardiovascular patients are a tricky or not really a complicated set, but once you're aware of what their history is, what their medical condition is, and then you have a detailed evaluation, every cardiac patient can have exercise as a part of their daily routine, no matter what condition they have. But it's all about the intensity, duration, and frequency. So myocardial infarction. So can people post-MI exercise? Yes, they can, but at what level? Now we need to understand that as a consequence of MI, they could be having scarring and the functionality, the ejection fraction, stroke volume, contraction force reduces. So automatically their baseline of aerobic capacity can be anywhere from 50 to 70% of a healthy individual matched to age and gender. So once we have an understanding of what the disease does to the physiological adaptation of the body, that's when you can prescribe exercises based on their limitations. Now, diabetes, as we all know, exercise is a crucial part. The importance of exercise in diabetes to have exercise more during the morning. That's wherein the insulin is the lowest and they have increased cortisol levels. So that's wherein they benefit the most. And exercise actually increases your insulin sensitivity and it also increases your resting fat oxidation as well. So those are the benefits that you have. So you got to be cautious about making sure that patients are aware of their blood sugar levels and they're monitoring, at least in the initial part. You don't want them to exercise if their blood sugars are less than 71. They have to make sure they take a few carbs, increase their blood glucose beyond 100, and that's when they're allowed to exercise. As I said, morning exercise are the ideal time because they have lower insulin levels, higher cortisol levels at that point. And once you exercise, your ability to, insulin sensitivity increases, and it lasts about 6 to 15 hours. So that's important to have those exercises early in the morning, so you have the benefits throughout the day. Now, the other side of it is you have to be cautious about hypoglycemia, and you have to make sure that the initial time they monitor it before, during, and after exercises. And once they have a baseline, they understand as to what level of exercises they can do, they can stick to the routine. And if you have your blood sugars more than 178 or 180, that's when you have increased chances of hypotension because of sweating, dehydration, hypocoagulability. So that's an extreme of hypoglycemia. So as long as you're in that range, you're aware of your blood sugars, that is pretty helpful. Now, hypertension, now these exercises are to be kind of contraindicated or cautious. Resistance training, isometric training, and high aerobic. Basically, what they do is they put too much of strain and they can actually increase their blood pressure significantly. So for them, it's more of the medium or low intensity exercises like walking, which are more rhythmic and steady state rather than high aerobic. And as we spoke earlier, Valsalva maneuver or trying to hold their breath while in exercise is something to be worried about in these people. People who are on medication like beta blockers, the medication can alter their heart rate. So when you're doing an assessment of their exercises, it's important to ask them whether the perceived exertion compared to just going with true values of their heart rate, for assessing the fitness prescription levels. And people who are on vasodilators, they have to make sure that they have a little more cooling time, especially if they're doing floor exercises and they change postures too often. They could be having postural hypertension, and that can lead to complications as well. So once we know each of these categories, it's safe for them to do exercises. Overweight, obesity is a major challenge that we face in our daily life. It doesn't matter which level of BMI we fit into, but exercise definitely has a significant role to play in obesity as well. But how do we quantify? Now, when you look at the BMI just takes into consideration the weight. It does not look into the contents of the weight. You know, majority of the water is what contributes to the weight. But when we look at the percentage of body contents, the body fat percentage is something that is the most important in terms of assessment in obesity. Two people of the same height and weight can have different body composition. That's wherein you have to go in a further step and assess the body fat percentage. There are various methods of doing it. The skin fold method I find is very accurate, easy to do. All you got to do is a caliper. You have a scale. There are various areas where you check for your skin fold thickness. And the important thing to do when you're checking for skin fold thickness is not to incorporate on any muscle or soft tissue. Basically, you just do the skin fold. Then you have the waist circumference that gives you a fair estimate. The waist to hip ratio is also a simple tool that you could use to see the body fat content as well. So what are the goals of people who are obese or overweight? So you have to have a realistic weekly goal, either half a pound or a pound per week. And they initially will be only able to do 30 to 50% of the aerobic capacity. A big challenge with people with obesity or overweight is their inability to do high intensity exercises for long duration. So that's where in the HIIT or the high intensity interval training is beneficial for them. But you have to have a word of caution in here is they could be having other coexisting conditions like diabetes, hypertension. So whenever you have a patient who's exercising with a cardiovascular condition as a coexisting or a comorbidity, that takes the highest priority, and that's where you have to focus on. So what I mean is someone who's obese, two individuals who are obese, one without any comorbidities and one with comorbidities. The one with comorbidities, the limiting factor is going to be the comorbidities for exercise prescription compared to someone who's absolutely healthy but just has a higher fat content in their body. So a word about coagulation and DVT, which is significantly higher in our population. There's no evidence saying that it can prevent directly, but they have studies that show that the incidence is lower in people who have exercise. So it's not curative, but the finding is that there is reduced incidence primarily because the major factors are genetic and the coagulation cascade and other important parameters. But physical activity has seen to change the fibrinogen level, so that is kind of encouraging. And we all know not exercising and being sedentary is a risk of DVT. So if you correlate that, we know that exercise is beneficial in people who are at developing DVT, at risk of developing DVT. COPD, it's important to focus for them on the upper body exercises and have them do the eccentric exercises compared to concentric, because your oxygen need demand is more in the concentric. So eccentric exercises are beneficial for people with chronic obstructive pulmonary disease. Rheumatoid arthritis, I'll be talking a little about arthritis too, but mainly the focus for people with arthritis has to be on improving the range of movement and to improve the strength. So the focus initially is to get maximal range. And what happens is when they exercise, they have increased blood flow, which kind of helps better mobility and they feel better as well. So sometimes in patients with rheumatoid arthritis and other arthritis, it's important that they can have water-based exercises that kind of unloads it, and that also prevents them from having quick movements or instability, so that they kind of protect their joints at the same time have maximum benefit. They could do it in a hot water tub or even apply heat before and then do the exercises. So this is just a graphic representation of the same. Now, cancer, that's a significant coexisting comorbidity that we see here, and that is a major factor. In fact, we saw that it's in the top 3 causes for mortality in here as well. So what kind of exercises are beneficial for people who have cancer? They require more of strength training, and then there have been studies that show that if you exercise regularly, the bowel transit time reduces, so your exposure for your intestinal mucosa for carcinogens reduces, so that kind of reduces the incidence of colon cancer. Similarly, there have been studies showing that exercises are helpful for reduction in breast cancer and prostate cancer as well. And of course, you boost your immunity by doing exercises, so automatically your risk of developing infections in patients with cancer also significantly reduces. So this is again a busy slide. So it definitely, what all it says is there is strong evidence that cancer-related fatigue, health-related quality of life, physical function, anxiety, and depression, they all have benefits from either aerobic, resistance only, or a combination. Now, a word of caution in patients with cancer is you have to make sure that they have a detailed evaluation, because they could be having risk of fractures because of pathological bone. So that's something that has to be evaluated. So when we speak about the high risk, they definitely come under the high risk, but once you do an evaluation and they have follow-up on a regular basis, then it makes it easier to give the right kind of prescription for these patients. Pregnancy, it's not really a disease per se, but because it's a physiological changes I've included as a part of my presentation, so that they can have reduced maternal weight. It basically helps them reduce the chance of low back pain, reduces the incidence of gestational diabetes. And also in these conditions, they have to make sure they don't do the Valsalva maneuver, because the hemodynamics can change and affect the fetus as well. So aerobic activity is ideal for them, low intensity or moderate intensity based on their baseline levels. They definitely cannot participate in any contact sport, and everyday activity is definitely beneficial for them. And the cumulative 150 minutes per week, that's kind of standardized for across all patients. Now, the other important physical activity that they can include is the pelvic floor muscles, stretching, and yoga, which is very beneficial for them during pregnancy. Coming to children, we see that these days the incidence of childhood obesity is on the rise, so it becomes very important for them to start being active at a very young age. And these are some of the strategies that you can have to try and make sure that they have more physical activity, less screen time, better sleep, and of course play as well. So from the age category up to 5 years, they can have about half an hour of activity, and once they go older, they need about 1 hour of physical activity. So the various categories that they could have is vigorous aerobic activity, muscle strengthening. You have aerobic activities as well, like cycling, swimming, and then bone strengthening as well. The elderly patients, for them, the focus is going to be more on trying to maintain what they have or lose at a lower pace. We know that we lose muscle mass at a significant rate, and then also your metabolism comes down. So we want to make sure that in the elderly, you have more of a maintenance, and it's beneficial for them to have seated exercises, because you avoid the risk of fall. Someone compared to standing and exercising, and you have them seated, so you're avoiding the risk of fall. Machine weights compared to free weights, because free weights, they're not in line, so they could lose balance of that particular arm and go off balance too. So machine weights are more beneficial for elderly, and the focus has to be on strength, flexibility, and train them to be independent. So it could help them improve their muscle quality, coordination, fall prevention, balance, and range of mobility and flexibility. So some of the activities I could do is walk in line, heel to toe, but again, we have to have a baseline as to what their balance and coordination is before we go on to these challenges that we want to put as a part of their evaluation. Now, the other types of physical activities are stretching, range of movement, combination, and walking, and making sure you have more number of steps incorporated into your daily living. So coming to the pandemic, no presentation today is complete without mentioning about COVID-19. So exercise does play a role in COVID-19. So we'll look into that. The main changes are going to be change of aerobic activity from outdoor to indoor, wherein you could play some music on your television or YouTube, dance to your favorite songs, indoor exercises, multiple apps. You have multiple equipment that you could have at home for cardiorespiratory training. Strength training as well. You could have someone, teach you how to exercise either via telemedicine, follow instruction videos on YouTube or other useful resources. And I would highly encourage physicians as well as patients to use American College of Sports Medicine. They have a lot of literature, flyers and handouts that you could even email patients, WhatsApp patients, that they could watch videos and understand and make sure they have a safer, healthier exercise regime. So some of the questions that, I'm at a quarantine but not infected. Should I limit my physical activity? No. Will exercise help prevent me from getting the virus? Well, it's not that it can prevent, but definitely your immunity gets boosted. So that definitely has a positive impact. So there's more data on the CDC that you can get regarding exercise and COVID per se. So what exercises can you have at home? You have kettlebell exercises, free weight, resistance band. I feel resistance band exercises is probably the most cost effective, beneficial exercise with low chances of injuring yourself. You don't need much space as well. So that's something that you could consider to have at home, no matter what age category, what fitness level you have, because you get resistance band at different resistance for different intensities of exercises. So coming to the take-home message is basically staying indoor. In the current situation, you could do these exercises, which are a combination of aerobic, strength training, and core stability. I mean, this presentation would be better if we had an outdoor gathering, so we could actually have a session, hands-on, and then teach it to our patients too. But you could have various demonstration videos in your practice, so you could explain to the patients how it needs to be done and do it safely. So the take-home message is we got to start simple. We got to make sure we examine our patients, evaluate them, make sure their risk stratification is done to see whether they're in high risk, medium, or low risk, and keep them motivated and make sure they exercise. So exercise is a great tool for most people once you have a medical clearance. So this is an initiative by the American College of Sports Medicine. They have it called as exercise medicine. This is, I'm actually happy to know that some physicians here have actually incorporated this into their practice. And this is how you can have a handout to your patients with frequency, intensity, time, type, number of steps per day. That's been an add-on with the invention of pedometers and the fitness tools. And then you can focus on cardiac as well as strength training for them. So yeah, that's what I have for today. So thank you. So that's exercise is the only prescription that you can have unlimited refills, and you take one step at a time. Any questions?
Thank you very much, Dr. Goud, for that explanatory presentation with so many practical tools. A lot of the questions that we would have had, you've answered along the way with all your tools and strategies. That being said, one of the questions were, what are some of the tools that you use to motivate patients to start exercising? And I see that you did put up some strategies there. That being said, in the Bahamian setting, what do you think is the greatest challenge to motivating patients to exercise from your experience so far?
Well, I think, first of all, it is the lack of awareness in people that exercise can be done in patients. Because usually when you think about exercise, they think it's for people who are already healthy, that they And the number one reason they think we need to exercise is weight loss. But that's not true. Once you start talking to them that the need for your prescription medication is going to reduce. And I haven't gone into detail about each of these conditions much because of the time constraint, but even, let's say, pre-diabetic or pre-hypertension or stage 1 hypertension, there have been enough evidences and studies that show that actually you don't need to have medication. So your need for hospital visit reduces. Your need for spending money on those things. Even the whole burden on the healthcare system itself. And that's where we as physicians have played the most important and the crucial role. So I would say the first thing is listen to them, ask them as to what their challenges are, and work around it. It could be either whole environment based, like I have 2 jobs I can't do. So even exercises that can be done while you're at work. If you're on a desk, get up every 5 minutes, walk around, come back and sit. So that's something that I advise people with back pain not to sit for too long. So same things can be incorporated into their job site, into their family. If you have a child, I can't exercise, take the child out, put the child on a stroller, go for a walk. So you could work around what. So the most important thing is to find the challenges and then work around what we could come out with. Because not everyone likes to go to the gym. Not everyone likes to be on a treadmill. It could be just washing utensils, cleaning the house, cleaning up the yard. So there are multiple modifications that you could do, and based on their liking. A lot of us, a lot of them probably who like to dance, they don't have to really go to the gym. Play some music, exercise at home, dance at home. So there are various strategies that you could work around with.
Thank you. Is Dr. Ramphal, his hand was up. Are you ready with your question, Dr. Ramphal? Okay, and so while we wait for Dr. Ramphal, Dr. Andrea Griffith would like to, if we can. Oh, go ahead, Dr. Ramphal.
Sorry, couldn't find a mute thing. Dr. Goud, that was clearly how a lecture should be given and delivered by an obvious expert. And I want to commend the way that you handle that topic. You're obviously an expert in it. My comment was sort of related to the last bit that you talked about making the exercise sort of useful. One of the obstructions to exercise that I have personally encountered in myself is I just don't like to do work that doesn't result in a result, something tangible. And so I was wondering about, I think maybe what we need to do as a profession is to pay more attention to the last thing you mentioned, which is how you can do things while working or doing other activities that accomplish exercise, so that the exercise seems to have a tangible goal, maybe not early on in terms of weight loss or heart rate or etc., but in something that you can accomplish visibly. For example, one of the things that I'm wondering why somebody hasn't come up with, and maybe I'll come up with it, and in fact, maybe you and me will come up with it, is a sort of a generator. For example, if you pedal a bike, the bike charges a battery bank that then we can use when the power cuts, that kind of thing. And then one other comment I have, and don't anybody take this wrong, but one of the things I've noticed since coming to the Bahamas now nearly 15 years is that people, regardless of their age, they seem to walk extremely slowly. Like even in the hospital, the young doctors and interns, they just stroll very slowly. And one of the things I've always said to people is you can just try to consciously increase the pace at which you walk, even when you're walking through the hospital. And that might accomplish some of your exercise goals, however small. I don't know how you feel about these comments, but I just wanted to make them.
Right. So your first comment about the exercise generators. In fact, they've been installed in a lot of airports, a lot of public parks. I would say at least about close to a decade now. So they are there, but that definitely would be very, very beneficial. And that's the most beneficial in places where people have to wait in long queues. So it could be also at the national level or the healthcare system, wherein if you have to wait at the government office in queue, why not have a few exercise machines that you do there while you're waiting? Of course, now we got to be a little cautious about our tropical climate because it's quite hot and humid. So that is a challenge of having those things outdoor in professional areas. But yes, there are a lot of countries like Scandinavian countries and European countries where they do have public open access gyms right at the bus stop or at the park or right next to school, even where parents are waiting to receive their kids. They have like a group activity or exercise. There are various strategies that have to be incorporated. But as you said, it has to be specifically catered to the kind of community we live in. So there definitely, I'm sure, there is something in the pipeline or should be out soon so that the exercise activities for our general population itself is going to be on the rise. Coming to your second point about activity at workplace. Now, as surgeons, we know we wait in the theater lounge waiting for our patients to be shifted. Now, that's an area where you could say, okay, instead of doing rounds one go, I go see one patient, come back. Depending on your time, your ability, and your motivation, you could start increasing, seeing patients twice. So those are ways that you could incorporate because once you're in hospital till you're done for the day, you're there. So if you have free time rather than sitting, so we could walk around, see what's happening. So those are ways that we could incorporate into our profession.
Thank you.
Thank you, Dr. Rampal. And Dr. Goud, lots of congratulations on a great presentation, excellent presentation. Roseanne Knowles-McPhee. Dr. Vani, who says she's very proud of you. She's your teacher from Manipal. Dr. Phyllis Darville and Dr. Griffith Bowe would like to know if we can have access to some of the questionnaires and tools that you presented.
Definitely. As I mentioned, American College of Sports Medicine at their website, I'll be happy to share the links as well. They have a lot of data, a lot of handouts, a lot of printable data, or even you can send electronically. And they even have it for specific, conditions. There are probably a list of 20, 30 conditions that didn't include like asthma, hyperlipidemia, and a lot of the present conditions that we see on a day-to-day clinical practice that you could download it as a PDF and then use it. So I would recommend and advise all of us to have a look at the ACSM website, and they have a lot of information and data that you could use and access for free. And they do have a lot of symposiums, meetings, conferences. They even have certification where you can get yourself certified as an exercise prescription specialist or exercise physiologist, and even for a subset of categories like cancer exercise prescription. So they do have a lot of things to offer. So I think this is a good starting point, especially with the pandemic. I think the need for being active and healthy has become even more important.
Good. So if you put that together for us, we could post it on the website and send it out.
Sure.
Through.
Definitely. I'll be happy to do that. And I'll be more than happy to help anyone in terms of having a protocol or help them set up for their patients. I'm always accessible. So I'll be happy to assist anyone.
Thank you. So we have another comment here, great presentation. I appreciate the use of physical activity as a vital sign and the base knowledge of exercise prescription. Can you comment, hold on, I lost the question a little bit. Can you comment on the use of movement screens for patients with musculoskeletal concerns?
I'm sorry, I didn't quite get that question.
Can you comment on the use of movement screens for patients with musculoskeletal concerns?
Okay, I'm not sure what exactly they mean by movement screen. So if they can unmute themselves and explain a little better, maybe I'll get it.
Yeah, can you hear me?
Hi, Dr. Goud. How are you?
Oh, this is New Bowl. Okay. Yes.
My question was more in alignment with, you did an excellent presentation as it related to, like I said, vital signs and exercise prescription, but it seemed for me, yes, it covered more of, let's say, sinister events, anything that was kind of life-threatening with regards to the use of exercise as a prescription. But I wanted to know, with musculoskeletal problems, when we look at patients who've had either past injuries, past issues, past that kind of stuff, when you offer them a prescription, can you comment on the use of a movement screen before offering a prescription when we look at?
So if I'm probably not getting the term movement screen, what do you mean by movement screen?
So let's say, for instance, looking at how someone does a squat, how someone does a lunge, how someone does a particular movement, the movement quality, the movement coordination. Certain things may be inhibited, certain things may be tight, certain things may be that kind of thing.
Right. So coming to the basic principles of exercises in people with musculoskeletal problems or joint problems, the focus, as I told, has to be on range of movement. So we want to achieve the maximal range of movement before we actually start putting strain on those joints exercises. So sometimes they can have a restricted range of movement. Now that's the range they can work in, and that becomes a limitation. So that's when we prescribe, we kind of evaluate as a musculoskeletal specialist that they have restricted movement in this joint, and we know that they cannot go beyond that. So we have to try and maintain that particular movement, and any exercise that can kind of put them at risk or off balance because of the joint stiffness, like you're doing a squat and you have issues with the hip or knee and you're not able to take it to the full range of movement, that's when you're exposing yourself to a fall or an injury by the exercise. So that's wherein when you do your initial evaluation, you go through a complete list of what their restrictions are, and then you have to cater your prescription around it. I don't know if I answered your question, but
Yes, you did. I just wanted to make sure that that was put out there where before the prescription, to say, actually look at the joint by joint and the movement qualities before saying, okay, do this, walk this, that, or the next, because
yeah. So it applies to all the specialties, like children with obesity, or be someone who's had a cardiac event or respiratory event or COPD. So we don't just want to have someone who has COPD and prescribe saying that you could lift weights. Now, strength training is one thing, resistance training, but you have to understand there are two components. As I said, you have concentric and eccentric. So for them, you focus on the eccentric. So once you have a basic knowledge or understanding about what their limitations, what their needs are, and that's where you have to tailor the prescription based on that.
Thank you very much. There are no more questions, and Dr. Verinder says great presentation. And before we close off, I'll just give everyone a little bit of medical trivia. You talked about lifting the kettlebell very early on in your presentation, and it reminded me of the medicine ball. And the medicine ball is a term that still exists today in the gym. It's a heavy-weighted ball that's used for strength training and physiotherapy. And Hippocrates was known to have stuffed animal skins and given to his patients to throw back and forth at each other for medical therapy. So I thought that I would share that. And so thank you very, very much, Dr. Gowd. Lots of congratulations on the presentation. We'll be hearing from a lot of our doctors probably asking for assistance with how we go about writing these prescriptions.
I'll be happy to assist. Thank you.
And we will get those lists to you through the website. Our next presentation will be on Friday, the 30th of October. We will be having a presentation from radiology by Dr. Power, and he will be concentrating on the non-pulmonary manifestations of coronavirus. So we will see you on Friday, the 30th of October. And please remember to sign into the Sunshine Lena website. The link has been placed there, and your assessment to claim your CMEs. Have a great day, everyone.